Oturumumuzun ikinci konuşmacısı Sayın Manoel Galvao NETO. Hi, Dr. NETO. Could you hear me?
I do.
Hi, hello. So I will introduce you in Turkish briefly to the hall, and then I will ask you to start your presentation. Thank you very much again for joining us. Doktor Galvao NETO obezite cerrahisi alanında önde gelen isimlerden biri olarak kabul edilmekte olup yenilikçi ve dinamik bir eksperdir. Bugüne kadar başta Latin Amerika ülkeleri olmak üzere tüm dünyada 200'ün üzerinde meslektaşının aktif eğitimine katkıda bulunmuştur. Obezite cerrahisi alanında birçok makale, kitap bölümlüğü, yazarlığı olan Dr. NETO halen Sciences Üniversitesi Indore, Hindistan'da klinik gastroenteroloji ve cerrahi profesörlüğü yapmaktadır. Yine Mohawk Bariyatrik Merkezi'nde Bariyatrik Endoskopik Kliniğinin direktörlüğünü, aynı zamanda Tijuana, Meksika'da yine Bariyatrik Endoskopi Bölüm Başkanlığı ve Uluslararası Bariyatrik Kulübü İnovasyon Direktörü olarak görev yapmaktadır. You don't need to be being presented, but I just briefly described to our hall. So please proceed. Thank you.
Thank you very much. It's a pleasure, a joy, and honor to be with you in this beautiful country of Turkey. And the matter of my presentation was already disclosed, so I will speak about bariatric endoscopy specifically. Endoscopic sleeve gastroplasti, and I'll take advantage of the words of the previous presentation of Professor Bergamassi of bandwagon. So this presentation, you will see how avoid creating that, because as innovators, we can create a bandwagon. So how we can solidify that innovation in the matters of science. So that's my intention to present to you. So as disclosed, I work in India with Dr. Mohit Bandari. I work in Mexico with Dr. Elias Ortiz, and in Brazil with this young team here. So what you have to offer to you all in 2023 in terms of bariatric endoscopy. So you see here we have interventions on the stomach. We have space occupying devices, and we can also alter the anatomy of the stomach by means of suturing or endoplacation. On the history, we have some attempts that didn't work very well, but you can see here at least the balloons and the endoscopic suturing, they are approved by the FDA, so it means they can be used in clinical practice. On the experimental field, still under investigation and trials, we have interventions on metabolic surgery. We can detour the path of the food, we can create magnetic anastomosis, we can even alter the mucosa of the duodenum. But let's get back to our presentation and who is in the game of obesity treatment. The number is 10, gentlemen. Why 10? Because 10% of total body weight loss percentually means around 90% of improved health or improving the comorbidities associated with obesity. And who is in the game? You see the new medications, the GLP-1 analogs, the bariatric endoscopy methods, and the bariatric surgery. So these are what we should rely in terms of treating obesity with more than 10% total weight loss, as you can clearly see here. Endoscopic sleeve gastroplasti in red to you put us 70 to 80% of the patients with at least 10% of total body weight loss at 1 year, and is getting better as a technique development. So this graph is very interesting to show you. In the vertical axis, we have efficacy. In the horizontal axis, we have lack of penetration. So you can see here what people like the most is the less efficacious, that is diet and behavior modification. And then you have bariatric surgery on the right side, on the upper part, the most efficient treatment against severe obesity. This middle part was like empty, and our vision is the bariatric endoscopy with the new medications can occupy that. So endoscopic sleeve gastroplasti, the machines we use right now, they were developed in the times of a bandwagon. That it was the NOTES, natural orifice transluminal endoscopic surgery. Big movement worldwide, like 10 years ago, that we thought that everything could be solved by transanal, transgastric, transvaginal surgery. And a lot of equipment were developed. For example, the one we're going to show you, they were developed to close the holes that we open in the times of NOTES. So that was time of bandwagon. But all this effort becomes endovascular now. So this is the machines you see. We are doing that for quite some time. Look at the evolution on the first machine to the left, to the right. And you see here clear evolution from the first machine left to right, double channel, generation 2, and then now the single channel ones that we have. So basically, the suture machine have two parts. One is the tip that is a needle, and the needle holder driver that we can use the two channels that are available to load the needle, open, and then we have the second channel where I have a helix that is a corkscrew-like grasp or grab tissue. We pull inside, we close it, and then we exchange the needle one side to the other. So the intention is to do and work in the gastric body, as you're going to see here. So at 3 o'clock you have the incisura, where you work in the greater curvature, anterior wall, greater curvature, posterior wall. Then we go up, you're going to see right now, on the posterior wall, and we go back until the anterior wall in a U-shaped matters. So we let go the needle, it works like an anchor. Then we have like a knot pusher with a clip. So we pull the tissue, we compact the tissue, as you can clearly see here, and we fire a clip so we can apply suture on the gastric body up to the gastric fundus. So we have a significant reduction of the volume of the stomach. So you can see here how the movements, they are very repeatable, they are very like relaxed. So you grab the tissue with the helix, you put inside the two towels, you close, you recover the tip of the needle, then you go like a suture should be. And is what you have on your screen right now. So you can see the indentation and the shrinking of the stomach, and we oppose serosa to serosa. When we oppose serosa to serosa on the outer layer, it will be grant the durability that we have up to now. It's not the suture, but it's the apposition of the serosa to serosa. You see this accordion effect in front of your eyes. So how it looks, you see here a 3D reconstruction during the procedure, and now just after the procedure. So you clearly can see that we reduce the volume of the stomach on the gastric body. Also, you can see here this is a 3-month 3D reconstruction. You can see the stay there, and an X-ray. You can see that really we go to the fundus, to the body. And if you see that, we can even tell you that it looks like a zygostrectomy. But if you narrow your eyes, on the upper part, you're going to see a gastric air bubble because we don't do all of the fundus, so it's not really the same. CT scan showing you the suture part in red and the functional part in green. And this is just to show you how it is just after. So we're going to see here at 3 o'clock, the smaller curvature, the incisura. At 9 o'clock, we will see the sutured greater curvature and how we can build a tubulized channel for what it is, the endoscopic sleeve gastroplasti. And now we are in the esophagus. Almost there, it's a long tube. Okay. So how it works, you can see here this beautiful image from Professor Baham Abu Dayyib, Mayo Clinic. It's a dynamic MRI. So you can see the heart beating, you can see the liver, and on the side of the liver, you can see the stomach. And the suture part is the dark side, the dark part. But you can see the stomach is still moving normally because we keep the capabilities, innate capabilities of stomach of relaxing and contracting and that. So it's a more physiological procedure than just cutting the stomach. And this is a study that we use scintigraphy to show how it works. So you can see here on the color part, on the left side of your screen, that is still food in the stomach 240 minutes after the injection of the food. And on the right, the area under the curve graph, you can see from 0 to 3 months how we can positively or negatively impact the gastric empty. This is how it works. It delays the gastric emptying. So also, to show you on this paper from Italy, from bioengineer, they create bench models of normal stomach, gastric band stomach, sleeve gastrectomy, and sleeve gastroplasti, as you can see here. So take a look at L1, L2, E1, and E2. So in this way, this model, they pressurize it. So the upper part is not pressurized, on the lower part is pressurized. So more red, more pressure. So you can see here on L1 and L2, the sleeve gastrectomy models, narrow one and a broader one, that you really increase the pressure. So they are hyperpressive systems. And you go to E1 and E2, that's a sleeve gastroplasty, you see that this pressure is distributed, doesn't increase pressure that much. So this is our lower pressure, non-refluxogenic procedure. In terms of timeline, so you see, if you just type right now on your smartphones, you're gonna have 3,000 reference, at least 200 published or presented articles on that. So there's a lot on that. We started in 2012, 2000 and so. So you can see here, the suture is not new. You have these old suturing machines that didn't work well, but the beginning of what we're gonna do now. So then you see here, even get to the mainstream media on the Professor Christopher Thompson from Harvard. He had done and published some results, but the machine got perfected. And when it's perfected, so Dr. Thompson did some cases in India in 2012, and at the same time we are doing cases in Panama, and we present in 2013 stages, the first video series of those cases in Panama, that we designed what the technique should be done. So not doing the antrum, doing the body, a little bit of the fundus, but the first patients of 6-month results were very encouraging. And also it was an IRB approved, so 36 to 28 was 29 was very encouraging on that. And at the same time, Professor Bahama Budaye on Mayo Clinic, they published a small series of 4 patients, and he crafted the name. So the name given was endoscopic sleeve gastroplasty, that anatomically can be questionable, but is the name that you have to follow. So then Professor Ring Sharaiva from Cornell did a small series and presented and published in Endoscopy. And we in Europe, together with Professor Gautama Pesnava, present the first 6-month series and the first 1-year series that was followed by others, as you can see here. So it was disclosed in the bandwagon things, you have to be reproducible. So we just jumped to a multi-centric trial with 1 center in Spain, our center, and 2 centers, Cornell and Mayo Clinic in United States. So suturing different way, collectively, you see here in red, we got at 18 months, 19.78% of these 248 patients on that. And you can see here the weight loss was very interesting to that. And remember that 10%, we get 85% of the patients in with 24 months with at least 10% of total body weight loss. So we get back to Brazil, we start our experience in our university, ABC University, and then we have 2 landmark trials. The first with initial experience that we get 15% total weight loss with around 2% of severe adverse events, no mortality on that. And then with more people involved, with more experience, we published this paper with 19% total weight loss percentually, and 1 bleeding as severe adverse event. Interestingly, you see the first paper published in Gastrointestinal Endoscopy, a gastroenterology journal, and this one in Surgical Endoscopy, a surgical journal. So we progress on that, and we gather people that we have trained, and we get a consensus with 1,828 patients with 18.2% of total body weight loss at 1 year. And you see here very experienced endoscopists and surgeons, so GIs and surgeons together, but all trained in the same way in the suture that we use, the U shape that we help design. So you can see here what's important. At that time, the meta-analysis were pointing for 2% of severe adverse event, and we could lower for less than 1%. And you pass in a needle, so you can have bleedings, perforations. You see here one patient that the gallbladder was punctured, and it was have 1 death with a pulmonary embolism 10 days after the procedure in a high-risk patient. So after that, we have to call out and see a long-term results. There's 2 papers, one from Cornell, 5 years, and a very recent paper from us in India with 4 years follow-up. You can see here good follow-up that we follow our patients very closely with phone calls or having person. So at the end of 4 years, you can see here 18.19% of total body weight loss percentually on that. And a very good resolution of comorbidities, basically because the patients effectively lose weight. So comparative studies, how we compare with other techniques, surgical ones. So we begin this study that was presented in Obesity Week 2017, and then it was published in Endoscopy years later, 2-year studies comparing endoscopic sleeve gastroplasty with sleeve gastrectomy and laparoscopic greater curvature plication done by robots. You can clearly see on that slides that the surgical group lose more weight and is significant. But 18% is not that bad after 2 years for endoscopy. The trade-off, we have significantly less complication, less severe complication when compared with the surgical groups, and also patient stays less in the hospital with the endoscopic procedure. And also we have very recently from gastrointestinal endoscopy a very interesting paper from Professor Ayed Al-Khatani, Saudi Arabia, on a pooled group of 3,000. They did a case match study aiming for no inferiority. So they set up 10%. If endoscopy is 10% better, is superior. If it's 10% less, is inferior. So look at the second column, and you're going to see that endoscopic group at 2 years have 14% total weight loss percentually. And the surgical group, the sleeve gastrectomy group, have 19%. So it stay in the range of 10%, so it proves no inferior. And if you progress to the right side column, you're going to see that no inferior in terms of comorbidity resolution and adverse event. And even more, go to the last column on the right, and you see with your eyes that we can redo by endoscopy what we have done, and we can convert to sleeve gastrectomy safely without severe adverse events in this series and other series that go on that. Even more, from the beginning, we thought that we can combine what we are doing by suturing, adding GLP-1 analog. So let's see, as this paper published in gastrointestinal endoscopy, that at month 5, we add in one group, we add the GLP-1 analog, the liraglutide. So let's see the results. You see here is a case match study again, 26 patients each arm. And you can see here, when we apply the liraglutide, the delta in between the group without medicine and the group treated with medicine is from 24.7 to 20.5. So it's a very good delta, and 24% is a lot of weight loss, very close to sleeve gastrectomy. We also have a randomized trial with a more powerful GLP-1 analog, that is semaglutide, applied in month 2 in a group that. So you can see here, there's the flow chart, how we randomize it, and the delta is even higher in between the ESG plus semaglutide against ESG solo. So you can see here that we can even go to higher and better results. And at the end, we achieved the level 1 evidence. That is in US, it's called MERIT trial. And it was, you can see the institutions that participate, a randomized trial against diets: Mayo Clinic, Cornell, Harvard, University of Texas, Johns Hopkins, University of Chicago, and private centers. So very important centers, very serious centers were on that. And the design was 200 patients. And from these 200 patients, 40 patients need to have hypertension, and more 40 needs to have at least diabetes. So from these 200 patients, they were randomized, 80 were randomized to have the procedure, and 120 were randomized to have the diet and be followed. And after 1 year, they will be offered to cross, meaning they can have the endoscopic procedure. So take a look to the right side of your screen, and you're gonna see here that in blue, they were the patients randomized to have the procedure, they lose weight, and the dotted line vertical, when they cross it, they keep it. So in red, you see diet doing what diet does, almost nothing. So they don't lose weight with diet, but when you cross it and offer the procedure, it goes with the blue line and stays like that. Very important to note that the follow-up was during COVID, so the follow-up was not that intensive as it should. If you get back to the left side, 77% of the patients have more than 25% of excess weight loss, because at that time, FDA required us to use excess weight loss instead of total weight loss. But it's meaning around 15% of total weight loss is very good. And we have a delta of 45% better results from the intervention group when compared with diets. So adverse events, they are concentrated on the week 1, and most of them, they don't last up to 3 days. And 2% of severe adverse events, 1 perigastric abscess treated by antibiotics, 1 upper GI bleeding treated by endoscopy, and 1 case of malnutrition that the suture were cut and the patient reversed that condition. Comorbidity resolution on the upper part, on this green circle, diabetes resolution 90% or improvement, metabolic syndrome an 83% improvement of resolution and 67% improvement on hypertension. So it's very good results. To show to you and prove this procedure is not refluxogenic. So compare this data with data of sleeve gastrectomy, and you see that we didn't induce any new case of reflux in comparing with sleeve gastrectomy that is really a refluxogenic procedure. So on the top of that, we were able to publish that in Lancet. So it's a very well accepted paper, very well recommended, level 1, prospective randomized. Also, we have some data proving that we can do in more in class 3 obesity, because in the first one, this merit trial was 30 to 40, but it's now data showing that we can use more heavy patients. I still prefer to stay on 30 to 40 on that. Pooled data, meaning meta-analysis. So that's the most recent meta-analysis, gentlemen. 15,714 cases of ESG in peer-reviewed literature. And the pooled severe adverse events is 1.25. And if you see 36 months of 14%. So this is really consolidated data, reproducible data, showing us that this procedure, it is indeed safe, results are reproducible, and the data in meta-analysis and level 1 show us that we can use that in comparable data. It can use now this as, how can I say that, a new bariatric procedure. So for the sake of time, I will stop here saying to you that we recently, just last year, we got this year, on the beginning of this year, we got approved by the FDA, not the device, but the procedure for 30 to 50 BMI, as well as revisions of bariatric surgery for insufficient weight loss or weight regain. We also get approval by the FDA. So that's what I wanted to show to you. And I'm here for any questions that you have. Thank you very much.
Dear Professor Neto, I appreciate for your excellent and innovative presentation on behalf of all audiences. And the results are very encouraging and achieved strong level of evidence. Thank you. So I will now ask to the audiences, and let's get back to you, okay, for questions. Salondan
Okay.
soru ve katkısı olanlar varsa buyurun lütfen. So I may have some questions if you don't mind. So what about the super obese patients? Is it as effective as the same in if you categorize? Of course, you have some subgroup evaluation for those, but could you briefly explain to the audiences?
Absolutely. So in super obese, it is not as effective on the lower BMI patients. That said, we have been using quite some cases for super obese as a bridge to the definitive procedure. We published a paper with Professor Ricardo Zoron in Charité Hospital in Berlin that we only take patients with higher BMIs, 55 and over, and impenetrable abdomens candidates to renal transplantation or to liver transplantation. And they went very well with around 12% total body weight loss, and they could get this weight loss to have a more safe procedure or even to get back again on the waiting list for transplantation.
Thank you. And in your complications, in your slides, I saw bleeding and collection were similar to the conventional laparoscopic sleeve gastrectomy. So, is there any other different complication did you ever notice in your series?
Basically, no. And this is the beauty of this procedure. Chronic complications are my limits for pain. If one of the stitches is still in the abdominal wall on the peritoneum and you just cut it, it's going to be okay. So malnutrition, ulcers, late bleedings. Basically, we say that you have a window of 7 days to have a complication. If you don't have it, it's going to be very difficult you to have another one.
Yeah, it's also related with individual factors too. So, thank you very much. It was a pleasure to listen your experience and your large series with excellent studies. So, thank you very much.
Thank you. Thank you. Pleasure and honor and a joy. Thank you. Bye-bye.
Bye-bye.